Hi, my name is Antonio DaCosta. I'm a third-year medical student from Florida Atlantic University, Charles E. Schmidt College of Medicine, and today I'm presenting a unique and, to our knowledge, first documented case of simultaneous iatrogenic aorto-left and aorto-right atrial fistulas following a transseptal catheterization procedure, which was successfully repaired using vascular plugs. Now, aorto-atrial fistulas are rare. They're typically associated with infective endocarditis or prior cardiac surgery. When they do occur, they usually involve the right atrium, given its proximity to the non-coronary sinus of Valsalva. Left atrial involvement is far less common. Historically, management has relied on open heart surgery. However, recently, percutaneous techniques using devices like the Amplatzer duct occluder 2 have emerged as alternatives, especially in high-risk surgical patients. This case involves a 73-year-old male with a complex cardiac history, prior ASD repair, coronary bypass, ischemic cardiomyopathy with an ejection fraction of 25 to 30%, and persistent atrial arrhythmias. He presented for catheter ablation. During the transseptal puncture, the sheath inadvertently entered the aortic root via the non-coronary cusp. Imaging later confirmed not one, but two fistulous tracts, one from the aorta to the right atrium and another to the left atrium. In our images at the bottom of the poster, you can see the CT images that demonstrate both fistulas. Figure 1 shows the communication to the right atrium, and Figure 2 captures the connection to the left atrium. This dual fistula configuration is exceptionally rare and had not been previously reported as an iatrogenic complication. Now, given the patient's prior sternotomies and patient's Lima graft, surgical repair was ruled out. Instead, we pursued a percutaneous approach. We used a 6x6 Amplatzer duct occluder 2 to close the aorto-right atrial fistula and a 4x6 Amplatzer duct occluder 2 device for the aorto-left atrial communication. Both devices were deployed successfully with excellent positioning and no significant residual shunting. The patient was discharged home the next day. This case adds meaningful insight to the evolving field of structural heart intervention. It illustrates how percutaneous closure can be a viable and effective option, even in complex, high-risk anatomy. More importantly, it highlights the need for procedural awareness during transseptal punctures, especially in patients with prior cardiac surgery. This is the end of our poster. I want to thank you for your attention. I hope this case contributes to a safer procedural planning and broader adoption of percutaneous techniques in a similar setting.